to make sure that everybody is seeing my screen and hearing my voice well. For the attendees, I can see above 200 attendees now. You can communicate with us through the chat. And please let me know if there is any technical problem before we start. Thank you again, Dr. Zakaria. I'm honored to be here today, and hopefully these difficult days will be soon away, inshallah, Rabbil Alameen. Again, I would like to thank everybody who had the effort and time to organize this meeting, and hopefully it will be a useful one. I would like to thank the Jordanian Ophthalmology Society for the continuous efforts during the lockdown to be always in touch scientifically. And also I would like to ask or thank the Middle East Hospital for the kind invitation. And also I would like to thank Orchidia for, again, the continuous organization of the scientific gatherings and meetings. In my presentation today, I'll be going step by step in a systematic approach to deal with keratoconus patients. As you are all aware, keratoconus is very, very common in our area, in the whole Mediterranean area, and particularly in the Middle Eastern area. And most of the information that probably I'm gonna go through in this presentation is sort of well known to all of you. And my presentation, the goal of it is just to go through that step by step in a decision tree fashion. I have nothing pertinent to disclose for this presentation. As you all know, corneal ectasia is a group of non-inflammatory disorders characterized by corneal weakness or thinning, in which the protrusion of the cornea leads to irregular astigmatism and poor visual acuity. And this is a large group of disorders that comprises primary conditions like keratoconus, keratoglobus, and PMD, in addition to the secondary or iatrogenic causes like the corneal ectasia following refractive surgery. Whenever you face any patient with keratoconus, you have in mind two goals of treatment. The first goal is to stop or delay or herald the progression of the disease. And the second goal is, of course, why the patient is coming to your clinic, is to improve and restore and cause visual rehabilitation for the patient. So again, when you face a patient with keratoconus, you keep always these two goals in your mind. First thing, you have to stop the disease because it's a progressive disease. And the second goal is to restore visual acuity and visual rehabilitation. I can see another voice actually in
طيب ادي المودريتور هو فين بقى؟ شايف 227
Dr. Zakaria, can you hear me, Dr. Zakaria?
Yes.
Okay, because I can see a different voice, one of our friends speaking in Arabic, so I thought, no, it can cause some disturbances for the attendees. I hear that there is no problem with hearing from the chat that I see, so I'll continue for the sake of time. Again, this is my approach to deal with patients with keratoconus, or this is my decision tree. It's not something that I invented. It's not something that I wrote. It's just a summary or a collection from what I came across in the literature. And also I added from my journey with keratoconus patients over the last probably 15 years or more, what I felt that it's different in our community from other communities. So the first question that you have to ask yourself whenever you face any patient with keratoconus in your clinic is your patient progressing or not? That's a very important question because the whole plan of action will be different if the patient is progressing, different from the patient that's stable and have a stable cone. So the first question, again, you have to answer this in the first visit that you see the patient. Is your patient progressing or not? Sometimes you will not be able to get an answer in the first visit because you don't have any previous history of the patient, you don't have previous images for the patient, and you might need to follow up the patient to define this question. And sometimes you have a clue, and you will be able to take a decision from the very first visit to your clinic. In order to answer this question, we need to know the definition of progression. And I was hoping that we had more interactive, actually, session to be able to listen to the attendees and know their approaches and their definition of progression, but that's not the case now. So I'll go for the next slide to show you what I consider progression. Now, there are many definitions. If you go through the literature, there are many definitions for progression. More or less, they are talking about probably the same principle, but again, you have to have solid numbers to decide whether your patient is progressing or not. It's not only an impression that you develop. You have to have something in your hand that you can rely on to say that, yes, my patient is progressing. Now, one of the definitions is the one proposed by our friend, Professor Mazen Sinjab, in his academy, where he defined progression as an increase of 2 diopters on the Kmax and decrease in the corneal thickness of 15 microns on the thinnest location. And the two things should be there to define progression. So increase of 2 diopters or more on the Kmax and thinning of 15 microns or more on the thinnest location. Now, the interval doesn't really matter, because some will ask, should I do it every 2 months or every 3 months or every 6 months? It depends on your patient. If your patient is young, having bad behavior in one eye, probably you'll do it more frequent, the test and the topographies. But if the patient is relatively old, like patients above 30, I might do it every 6 months or every even 1 year. So if you prove this, that means that your patient is progressing. Another definition that came out from Ashiwari group in 2013, they defined progression as an increase of half diopter or more on the steep meridian in 2 sagittal curvature maps and 10% decrease on the thinnest point. And that's 6 months apart topographies. So again, this is another definition of progression of keratoconus. And to make life easy, always technologies come to help surgeons and physicians and ophthalmologists to take decisions. Now we have the software that you can purchase and upload to your machine, which is called the ABCD keratoconus staging software, and that also can give you an answer if your patient is progressing or not. It helps you. It doesn't give you the whole answer, because your impression as a clinician, as a doctor, will count the most. But at the same time, it will give you a very good idea. So those are the definitions of progression. Probably you have other definitions, but again, you have to be consistent dealing with who is patient is progressing, and to be able to get consistent results, it's better to compare images and topographies on the same kind of machine. I wouldn't recommend to compare a pentacam to an Orbiscan. And even I would like to compare the pentacam if you can on the same machine, but that's not possible all the time, because some patients come from outside or from other clinics or other centers with pentacam in their hand. But at least try to compare topographies on the same machine. Pentacam, Orbiscan, if you can do that. Now, if you decide that your patient is progressing, we go back to the decision tree. That means you know, and I know, that the patient needs cross-linking, because cross-linking is the only proven modality nowadays to stop the progression of the disease. There is no other modality that stops the progression of disease. There has been a lot of talk about the rigid contact lenses, about the scleral contact lenses, about the rings. There is no real evidence in the literature that proves that those modalities stop the progression of disease. The only one proven to stop the progression of disease is the cross-linking technique. And again, cross-linking is one of the really talks that I love to talk about, but it's a very lengthy talk, and probably it needs more than one lecture to talk about it. So I'll just go quickly in a couple of minutes about the techniques of cross-linking, because you've been hearing a lot about the techniques and the development in cross-linking nowadays. The original technique, the one proposed by Theo Seiler, the gentleman in this photo wearing the red tie, though he proposed it in 2003, which is like 17 years ago. So we have now long-term data to assess and analyze the efficiency of the procedure. He proposed the Dresden protocol, which is an EP-off technique and the standard EP-off technique, where you do 30 minutes of saturation with riboflavin or inhibition with riboflavin, and then 30 minutes with the irradiance with UV light. And the classical one was 3 milliwatt per centimeter square for 30 minutes. And this is still a technique that's very efficient, and we have very good results with it. However, the newer techniques came for many reasons. One of the most important things is to shorten the procedure time, because it was really too long to keep the patient for 1 hour in occupying one of the rooms in the OR, or even as an outpatient, he's occupying one room, occupying 1 or 2 technicians, in addition to the doctor coming in and out. So it was a very lengthy procedure. So the new modalities, one of the main goals to invent it were to reduce the time of the procedure, either reduce the inhibition time, the saturation time, like we see in the iontophoresis, or by reducing the irradiance time, that like we see in the accelerated cross-linking. The total irradiance that should be delivered to the cornea is 5.4 joule per centimeter square. Whether you are using the accelerated, you can increase the irradiance on the expense of time. For example, we have machines that give you 9 milliwatt per square centimeter for 10 minutes, or it can give you even 18 milliwatt for 5 minutes. So the total power or the total irradiance delivered is around 90 milliwatt per centimeter square, which is equivalent to 5.4 joule per centimeter square. We usually don't go less than 5 minutes in irradiation because the efficiency will become less and less because of oxygen depletion. In iontophoresis, it is pretty much the same principle. However, you keep the epithelium on and you enhance the penetration of the riboflavin by using electrodes to push the riboflavin through the intact epithelium. And nowadays, also, they are talking about Avedro introduced a technique talking about oxygen boost cross-linking, where again you keep the epithelium on, and the patient wears special goggles that gives him an oxygen boost, and this oxygen boost will help as an enhancer to improve the penetration of the riboflavin into the stroma. So again, different modalities, different techniques. The principle is the same: is to get the collagen fibers in the cornea to get cross-linked and to have the patient heralded his progression of keratoconus. And finally, the customized cross-linking, which is cross-linking for the affected area. The principle is that we are treating that diseased area. Why should I treat the whole cornea and ended up with some potential complication if I can treat only the affected or the protruded or the keratoconus part of the cornea? So that's in Harry the cross-linking techniques that we use nowadays. So the patient had the cross-linking, and we're done with the first part of the treatment, which is stopping or delaying the progression of the disease. Of course, we need to keep in mind that this patient still needs monitoring in the future to make sure that our cross-linking is effective and that the disease is really stopped. Now we'll go to the second part of the treatment, where you will need to increase or to improve the visual performance of the patient, because this is what the patient is caring about. The patient is seeking better vision. When you do cross-linking, he is not having better vision yet, and he might not be happy because he will say that his vision is even worse than before the cross-linking, because after cross-linking, we know there might be some haze that will reduce the vision for a short period of time. So the patient is always seeking visual improvement. And in order to achieve this second goal of the keratoconus treatment, we look at the best-corrected visual acuity. If the patient can refract to a good visual acuity, and here the cutoff point, we are talking about 0.3 and above, then you can consider treatment of this patient with one of two tracks. If the patient is having low refractive error, after cross-linking, the patient might be very, very happy with the glasses, because patients with low refractive errors, they do very well with the glasses, and they usually don't suffer a lot of aberrations, and it's a very safe thing. So you do the cross-linking, you give the patient glasses or spectacles, and that's it. And the patient keeps coming every now and then to check again for the success of cross-linking and the potential of progression. If the patient is not willing to wear glasses for one reason or another, he can go for the contact lenses. And in low refractive errors, even the soft or the soft toric contact lenses can help. And there is the controversial issues. This is a very controversial issue, the PRK following cross-linking in patients with low refractive error. We'll talk about it, but again, it's a controversial issue, but you should know what's going on in the world in terms of PRK for cross-linking. Now, if the patient is having high refractive error, the order of improving vision is different. They usually don't do well with glasses because of a lot of aberrations, so they cannot tolerate spectacles with high refractive prescriptions. They do much better with contact lens, and now contact lens development has been way better than years ago. We have the scleral contact lenses that are tolerable by a wide variety or wide range of patients. And also we have the option of Toric ICL, which is again an off-label use, but there has been an extensive literature on Toric ICL for keratoconus patients with good vision. And as I said, spectacles for high refractive errors are usually not the fair choice for the patient. Now, the surface ablation or the PRK for keratoconic patients. Now, before I go through this slide, you have to realize a few things. First of all, it's a controversial issue because you will say, okay, I will do it. Your colleague will say, no, this is absolutely contraindicated. And the patient should understand this, that this is a controversial issue. The second point you should understand is that we are not talking about refractive surgery here. It's not like PRK for a patient coming just for refractive surgery. It's not a refractive surgery. It's a surgery that we do only to regularize the cornea. We cannot promise the patient to get rid of refractive error that he has. We're telling the patient that we will try to regularize the cornea to make the refractive error less than what you have, but you will need spectacles, most likely. You might need contact lenses, and you might need to repeat the cross-linking in the future, because after doing PRK, we are basically ablating part of the cross-link cornea that we've done before. So you have to counsel your patient very, very, very well. Now, the first one to introduce the technique Athens protocol was Kanellopoulos, and Kanellopoulos in 2012 did simultaneous PRK and cross-linking. And, you know, it took like popularity all over the world. And for almost 2 years, everybody was a big fan of the procedure. I myself, I did, if not more than tens, probably 100 of such patients, simultaneous cross-linking and PRK. I'm not doing it anymore, actually. I'm not happy with the results, and I don't recommend that you do it. If you want to do PRK, it should be after cross-linking. And again, you should keep in mind the precautions that I told you about. But don't do simultaneous PRK and cross-linking. I've seen a lot of catastrophes following such procedure. Now, Toric ICL still is an option for patients with stable keratoconus. So you need to make sure that your patient is stable. So we don't do it before 6 months after cross-linking, just to make sure that the cornea is stable. Second of all, again, you tell the patient that this is not a refractive procedure. I cannot promise you to get rid of all the refractive errors. We reduce the refractive errors dramatically in terms of sphere and cylinder. But again, I cannot tell you that you will be zero refraction. You might need to wear spectacles after that. And in spite of excellent correction of the refractive error, those patients, they usually suffer from some disturbances in the visual quality, and that's related to the high order aberrations because of the abnormal cornea. But again, it's a very good technique. It's an easy technique, relatively safe technique. And if you select the right patient and you do the right measurements, which are a challenge actually, you can end up with really, really good results. Again, remember, patient with ICL because he has high myopia is different from a patient with keratoconus going for an ICL. Always keep that in mind. And you should tell the patient about that as well. Okay, so we're done with this part of the tree, which is the patient who can get good refraction with either low refractive error or high refractive error. Let's go to the other part of the tree. If the patient is not having a good refraction, I mean, he doesn't refract to more than 0.1 or 0.15. Whatever you do, the patient doesn't refract to really good refraction. Here you have to check again the cornea. If the cornea is clear, your way of thinking and your way of management is different from the patient who's having corneal haze or corneal scar. Let's go with the straightforward one. If the patient is having a clear cornea, the next step is to look for how steep the cornea is. If the cornea is too steep, and we mean by too steep above 65, the K readings, I think the only option left for such a patient is DALK, deep anterior lamellar keratoplasty, because all other techniques cannot be done. You cannot fit a contact lens over such a steep cornea. You cannot do cornea rings for such a steep cornea. And of course, you cannot do the other procedures that we just mentioned for a steep cornea, because you cannot do even refraction for such a patient. But if the patient has less than 65 K readings, which means that his cornea is steep, but it's not too steep, still you have the option of doing cross-linking for the patient, although the results of cross-linking in such steep corneas are not great. This is why some people, they say, no, I don't do cross-linking above 60. It's not contraindicated to do cross-linking above 60, but the results and the outcome of cross-linking after 60 is not that great. So I do, as long as the corneal thickness allows me to go for cross-linking, I do cross-linking for such patients, and I recommend also for such patients to do corneal rings. I'm not going to spend time on corneal rings because we rarely do it nowadays. Corneal rings, I started doing it in 2007. Probably I've done more than 500, 600 corneal rings over 3 years. But then after that, probably from 2010 till now, probably I didn't do 10% of that number. We rarely do it nowadays because we have better options. But again, you should know that there is still a place for corneal rings. Whenever you have a patient that cannot refract well and has a clear cornea, in contact lens intolerance, you cannot do anything for this patient except ring. Again, think with me. The patient cannot be refracted to a good visual acuity. His vision is like 0.1. At the same time, he is intolerant to contact lenses. Spectacles do not help. PRK cannot be done. ICL cannot be done because you don't have refraction and measurement for the ICL. And still, he didn't reach the stage of corneal grafting. So what will you do for the patient? This is the only option that you have in such a patient. And you face in the clinic such a patient every now and then. Remember, a patient does not refract well. He refracts only to 0.1. This patient intolerant for contact lens. You cannot do on such a patient Toric ICL. You cannot do PRK for such a patient. You cannot do spectacles or glasses for this patient because you cannot do refraction for him. So this is the only option left. What I'm trying to say, although corneal rings, we don't do it as we used to do it in the old days, but still there's a place for corneal rings nowadays. Of course, you cannot do it if the patient is having corneal haze, advanced keratoconus, hydrops, infection, or too thin corneas. Back to our slide and decision tree. We're done with all this. We are left with this category where the patient doesn't have a clear cornea. In such a patient where the patient doesn't have a clear cornea, that means the cornea has a scar or a haze. In this case, actually, you look for the scar either on the slit lamp or on a continuous OCT or on a shine plug image, and you can decide the depth of the scar. If the scar is superficial, I would definitely recommend to go for the DALK procedure. But if the scar is all through the whole thickness or a very deep scar, the only option that you are left with is penetrating keratoplasty. Here, there should be a video, but for technical reasons, I will not be able to run it. But what I'm trying to say here for corneal surgeons, that you are all familiar with penetrating keratoplasty. Deep anterior lamellar keratoplasty, which is DALK, is easier. Again, I stress again, it's easier than penetrating keratoplasty because you are dealing with a closed system, a very safe system, and there is no risk of doing it and starting with it. You don't need special instruments. You can use only the instruments that you have in the OR. You don't need to buy or purchase anything new. And again, what's the worst case scenario? Think about it. The worst case scenario is that while you are dissecting down to the descemet membrane is to cause microperforation in the descemet membrane. So what? If you cause that large perforation, you can easily convert to penetrating keratoplasty that you are familiar with. But if the procedure goes well, you can end up with much better results. No endothelial rejection, faster recovery, etc., etc., etc. So I encourage here in this talk, everybody to start doing the ALK, but you have to select the right patient. And again, keep in mind, it's a safe procedure. It's safer than penetrating keratoplasty. It's easier than penetrating keratoplasty. And in the worst case scenario, if you perforate, you can easily go and convert to penetrating keratoplasty. Now I'll try to end my presentation for the sake of time with just one clinical scenario that I actually introduced. It's not a real patient, but I try to simulate a patient to try to summarize what we had in the decision tree. Suppose that we are dealing with a 24-year-old male patient with poor vision, and his vision in the right eye is 2 meters, not improved with refraction. And this is the way he looks on the slit lamp, very advanced keratoconus, central corneal scar. And I'm not expecting answer actually to have an active interactive discussion, but I'll go through the discussion from different points of view. Now, for such a patient in the right eye, I don't think that we have a lot of options, because if we go through everything that we thought about in the decision tree, it doesn't work here. Of course, you cannot do cross-linking on this patient, although you know deep in heart that he is progressing, because I think that this cornea is not more than 200 microns in the center. Second of all, you cannot fit a contact lens on such a patient because of the very steep cornea. Third of all, you cannot definitely give him glasses because we said it doesn't improve the refraction, and so you cannot do neither toric ICL or any refractive procedure on such patient. So you are left with no options in such an eye except grafting. Now, which kind of a graft? Again, it's determined by the depth of the corneal scar that you have. So you have to assess probably in the slit lamp very properly, and then you can confirm that with either anterior segment OCT or the shine plug image that you have in your pentacam machine. So for such an eye, the only option you have is corneal graft. Let's go for his other or better eye. This is the left eye. This patient is having better vision in the left eye with a clear cornea. Now, the first message I would like to deliver from this case scenario is that would you do cross-linking or not on this patient? And how long will you wait before doing cross-linking? Will you wait to confirm that this patient is progressing or not? In this case, I wouldn't recommend to wait any single day, because you know that this patient, the keratoconus disease in such a patient is behaving really aggressively, because you have an evidence in the right eye, and you know that this eye will go down the hill very quickly if you don't stop the progression of the disease in such a patient. So in such an eye, I wouldn't go through the decision tree and say, okay, I'll wait for 6 months, repeat the topography, make sure that the topography is stable, etc., etc., etc. You know that he is 24 years old, so he has many years to progress. You know that he is behaving very bad in the right eye. You know that this is his better eye, so definitely you need to go for cross-linking from day one. You should not wait to confirm progression. This is the first message I want to deliver here. What kind of a cross-linking? It depends on the corneal thickness. If the corneal thickness is relatively in the good size, good thickness, and we mean by that above 450, I would recommend going for epi-off isotonic to make sure that it's an efficient procedure. If it's less than 450, 400 to 450, if you want to do the epi-off procedure, you have to use the hypotonic saline in order to swell the cornea and take it to a higher thickness. And if it's less than 400, this is a real challenge, because if it's less than a 400, would you cross it? The classical teaching that you cannot progress a cornea or cross-link a cornea below 400 because of the risk of the endothelial damage, okay? But think about it. This patient is having this only eye for the time being, okay? And even if the procedure outcome of cross-linking is not that great, but it's better than nothing, because you know if you leave him alone, he will progress. So for such a patient, any thickness above 350, I will cross-link this patient. Of course, there are different modalities. If the patient is having 350 to 400, you can use either the contact lens assisted cross-linking, or you can use the ionophoresis, the epi-on technique, or the oxygen boost epi-on technique. So there are modalities to deal with such cornea. But if the patient is having less than 350 cornea, then you are not having any options, and you need to just monitor the patient, avoid eye rubbing, and keep seeing him every now and then till he reaches the stage of grafting. So by that, I will end my presentation, and I Very happy to be with you today, and hopefully the coming days will be better, inshallah. Thank you very much.
Thank you, Dr. Wissam. Thank you very much. We have some questions. Can we depend on keratometry only to confirm progress?
Not really, because in keratometry, actually, you have a lot of flaws in the test, and you have to confirm the Kmax on a real topography machine and the thinnest point on a real topography machine. So keratometry is not a dependable, accurate procedure to assess progression of keratoconus.
Thanks, of course. Can we perform PRK first, then cross-linking?
Yeah, again, I repeat that this is a very controversial issue. There were 3 ways to deal with this. First, would I do PRK and then cross-linking? Or should I do PRK and cross-linking at the same time? Or should I do cross-linking first, then PRK? Every procedure has advantages and disadvantages. If you go for PRK first and then you do cross-linking, first of all, you will change the refraction of the patient after doing the second cross-linking. So you are doing a PRK on unstable cornea, and after doing the cross-linking over that, you will change the refraction that you got after doing the PRK. So the answer is no. Would you do simultaneous both together? Yes, you can do according to Athens protocol, but I'm giving you my own experience. It doesn't mean that it's the right thing, but this is what I'm convinced with, and I think most of the world is going in that direction. Doing simultaneous PRK and cross-linking is not a good option. You can end up with massive amount of haze. You can end up with very unpredictable results, and you can end up with unexpected complications. I think among the audience here, we have almost 300 audience. I think at least 10, they are aware of one of the cases that was referred to me from a colleague. A colleague did cross-linking and PRK at the same time, and the patient ended up with melting. It's not frequent, but it can happen. It was really a difficult procedure. I ended up doing a very large graft, reaching even the limbus to take care of all the melting. So again, doing simultaneous is not a good option in my point of view. The only option that I do, and rarely, I don't do it frequently, I do it rarely. First, I do cross-linking, and then 6 months after the cross-linking, when I realize that the patient is stable 100%, I consider correcting part of the refractive error, not taking more than 50 microns of the corneal thickness in order to regularize the cornea, as I said before.
Okay, this is my question. What about Toric IOL or ICL, and what is the success rate, you think?
Well, again, it depends on the stability of the cone. If the cone is stable, and you need to confirm that 6 months after the cross-linking by doing all the imaging needed. If the cone is stable and the patient is having a good best-corrected visual acuity, according to the literature and in my hands, I really had good and satisfactory results. I mean by satisfactory results, the patient is happy. I'm having a vision almost 0.6, 0.7, which is like 6.9, and the patient doesn't depend on the glasses most of the time. But you cannot do it for a patient who has unstable cone. You cannot do it for a patient who doesn't refract well. For example, if your patient has a stable cone, but you sent him for refraction, and the best result that you can reach with refraction 0.2, this is not a good candidate because he will not improve after doing a toric ICL. You have to have a good best corrected visual acuity, and you have to have a stable cone. If those 2 conditions are there, you can end up with really good results.
Okay. Here we have a very good question, I think. What are the signs of failed cross-linking?
Again, you can apply the same definition of progression on failed cross-linking. If you end up with increase of 2 diopters or more on Kmax, reduction of the corneal thickness after 6 months, this means a failed cross-linking. Of course, you don't do the cross-linking right after, because after cross-linking, if you do it corneal thickness after cross-linking 1 month after, all the corneas, they do have thinner cornea, because after cross-linking, the cornea is sort of dehydrated, and it takes some time for the remodeling of the collagen fibers to get back to the usual cornea thickness. But again, if you do it after 6 months and you have increase of 2 diopters on Kmax and more than 15 microns thinning on the thinnest location, this is considered a failure. But luckily, we don't see a lot of failures, especially with the epi-on technique. You have to be aware if you are doing an epi-on technique, you will face a significant number of, let's say, repetition in comparison with the epi-on technique. So epi-on technique is still more efficient, but again, it carries the risk of the epithelial removal, which is pain, haze, sometimes infection, etc.
When you are going to repeat the cross-linking, if there is any failure?
Not less than 6 months. And again, that depends on many variables. If I'm having a young patient, like a patient who is 18 years old, and with bad history in one eye, like the other eye is going for a cornea transplant, I will do it earlier than a patient who is like 30 years old with good vision in the other eye. But again, definitely, you cannot repeat it before 6 months, because if you do that, the corneal nerves are still not regenerated, the keratocytes are not back to normal, so you'll induce a significant amount of not only haze, but also scar.
Okay, here we have another question, please. Do you do topography guided or wavefront guided PRK after cross-linking or not?
Yeah, this is a good question because there has been a lot of literature. Now, most of the evidence says that topography guided PRK after cross-linked corneas gives better results than wavefront PRK. So in order to answer your question straightforward, I do topography guided PRK, not wavefront guided PRK.
Okay, please, another question. What about the age, maximum age and minimum age that you can perform the cross-linking?
To tell you the truth, there is no minimum age, there is no maximum age. But I'll give you some facts. We rarely see progression of keratoconus after the age of 40. However, there has been some reported cases after the age of 40. Very rare. And I'm talking about keratoconus. I'm talking about primary keratoconus. I'm not talking about pellucid marginal degeneration, because pellucid marginal degeneration can deteriorate after the age of 40. I'm not talking about post-LASIK ectasia. Post-LASIK ectasia can deteriorate even after the age of 50. I'm talking about primary keratoconus. We rarely see it deteriorating after the age of 40. But again, there is no rule that above 40, I don't do it. If there is an evidence of progression above the age of 40, and the patient coming to you saying that I'm having deteriorating vision, and you can prove that with serial topographies, still, there is no contraindication to it. But I don't recall that I've done any after the age of 40. None, zero. No minimum age. We used to say that keratoconus comes after the age of puberty, 13, 14. This is not true. I've seen a patient who is 9 years old. In the literature, there are some cases reported 7 years old. So you can do the cross-linking as early as you discover your patient. However, the technique will be more difficult because a 7-year-old boy will not be able to cooperate doing cross-linking under local anesthesia. So I had to do it under general anesthesia. So the technique will be different, but there is no minimum age. Whenever you discover keratoconus and you prove that this keratoconus is progressing, you have to go for cross-linking.
Thank you very much, Dr. Wissam. Thanks. It was very beautiful discussion.